Well, good morning, and thank you for inviting me here and to be the lead-off speaker for the section on infections. I am asked to present an overview of a systems-based approach to reducing infection rates, and as Fungi had said, I have been at Harborview for over 13 years in the Department of Medicine, and the medical director here for about 3.5 years. Today what I want to highlight are 3 major areas, beginning with just an overview, a societal view of some of these issues around infections. And then I want to talk about some of the tools and techniques that we have found to be very effective in helping to drive down infection rates. And then we'll go ahead and look at some results. There's a wonderful book. It's called The Cry and the Covenant. Has anyone here read that book? I don't even see any hands. This is a wonderful book. This is a book that was on our family bookshelf, and my father, who is a general surgeon, used to refer to it. So when I entered medical school, the first 2 books that I read were, of course, number 1, House of God, and number 2, The Cry and the Covenant by Morton Thompson. And this book made a lasting impression. This is the story of Ignaz Semmelweis, who, working in Vienna in the mid-1800s, could not let go of the finding that women who were delivering their babies on Ward A were dying at 5 times the rate of those who were delivering on Ward B, same hospital. And overcoming many of the institutional barriers to studying this issue, he knew that on Ward A, the junior doctors were delivering the babies. They were also doing the autopsies on women that had died of postpartum sepsis, known as puerperal fever at that time. And on Ward B, the deliveries were through midwives who were not doing autopsies. And it was when his colleague, who had sustained a scalpel injury during one of the autopsies, died of this same purulent process that characterized the autopsies of the women, that he knew that it had something to do with the cadavers. And in dramatic literary style, Morton Thompson writes that Ignaz Semmelweis saw himself dissecting women. They were dead of puerperal fever. He felt his fingers wet with pus and the fluids of putrefaction entering the bodies of living women. The contagion passed from his fingers to living tissues, to wounded tissues, and a new light blinded him. And this was his aha moment, where he was able to share with the world his understanding that as healthcare workers, we transmit infections from patient to patient through our hands. And that was 165 years ago. And while we have clearly adopted these principles in many of the procedural areas, the OR, the sterile field environment, it has taken us much longer to adopt the same discipline in all patient care areas, every patient, every time. And we are aware that society in general and many of the regulatory bodies and healthcare leaders such as Don Berwick and Atul Gawande are driving us to be much more consistent in applying evidence-based practices in our environment. Here, the CMS program called Hospital Compare looks at antibiotics that are given at the right time prior to surgery, as well as stopping antibiotics at the right time, with comparisons of any hospital across this country. They're also very interested in, was the right antibiotic used, minimizing the use of Foley catheters postoperatively. And here the Leapfrog program, also a live website, looks at ICU-acquired infections in a comparative framework. Here, the State Hospital Association on its website lists all the hospitals in the state, and it characterizes infection rates and many of the preventive measures relating to vaccinations, perioperative infection prevention, as well as agents used in prevention and treatment of pneumonia. And the impact of these very public, visible campaign-style efforts has been a dramatic reduction in infections. Here, just in Washington State over time, this is information put together by the State Hospital Association showing tremendous reduction in line infections due to central lines, with over 300 deaths prevented, $50 million in costs saved, and then 1,800 infections avoided. And as the medical director here at Harborview, and as someone who has long studied the measurement of healthcare quality and safety, I'm even more passionate about taking these principles to the bedside in an effort to make them relevant to the care we provide. Because as physicians, as family members of patients, and patients ourselves, we of course all want the same thing. We want the safest possible environment. And what I'd like to do is share some ideas and some observations about what appears to be working really well at helping to drive down infection rates and other safety initiatives. We were pleased several years ago to invite the University Health System Consortium. This is a program that coordinates quality safety efforts through many of the major academic medical centers. And we had invited them to a site visit to review our quality and safety program and compare our efforts with national best practices. And what they found was that we were, of course, extremely passionate here at Harborview and across the university system, very committed to the highest quality of care. But they said, you could probably do a better job at aligning your efforts from the board level all the way through the bedside. And they said you could be even more transparent with the data, and the best practices are really using transparency to great effects. So what we did with that, and this had a very major impact on the way we structured our program, is we started right here at the org chart level. Now this is a diagram that just shows the way we organized ourselves around the quality and safety program. And it really emphasizes the idea of partnerships. We had found over time that many of the physician groups were working really hard on improving care. Many of the nursing teams were doing the same thing, but often we were working in parallel. And we realized we had to bring all of that together. So beginning with the medical director, myself, working with the chief nursing officer, and then bringing in the entire executive team, what we did was we took a look at every clinical care area and made sure that there was physician leadership and nursing leadership, as well as others in partnership, leading the clinical delivery around quality and safety. This same then model takes us right into the level of the medical executive board, as well as the full board, establishing this idea of partnerships. And the infrastructure that supports the quality and the safety program is all dedicated to support for these clinician leaders. So one major area of interest is, of course, getting the OR started on time. So this is an example. So over a year ago, our group realized, boy, we've been working on getting the OR started on time for how long, and it's just not where we want it to be. So by putting it into a more visible format like this, setting a goal and starting to measure month to month, you can see that it was only a year ago that we were in really our historical baseline. And we just couldn't find the way to make this really come to the goal. And so initially, and there are many here that I'm sure can attest, the first thought was, boy, if only the nurses would do this. And the nurse would say, oh, if the anesthesia were able to be there on time, and if only the surgeons would mark the site on time. So we started to say, well, let's study the reason for every delayed case. Once again, there it is on the full screen for everyone to see month after month. The reasons for the delay. Well, everybody played a role. And we started to realize this isn't about finger pointing or blame orientation. It's let's look at this as a team effort. And we started to see that by studying each case, we could very quickly make the improvements that are reflected here in the actual cases that were delayed, even by 1 minute. Here's just another example. Core measures are on all of our agendas. This is a national mandate. Here's looking at the overall rate of adherence to 31 different measures for heart attacks, heart failure, pneumonia, and then perioperative quality. And this shows that by putting this into a very visible format, we're able to watch month after month, quarter after quarter, and at one point there was a slight dip in the results, and we were so busy working on so many areas that this one just started to drift. Well, we were able to quickly mobilize and not only improve that, but take it to really a new level. And in fact, here where we're looking at July, we just now have the August data that's now at 98%, which is all 31 measures being provided to these patients every time. And that's really an all-time high for this organization. Now let's look at the same graph as a subset around the surgical care improvement. So this is the 11 measures that characterize the perioperative measures. Many of those relate to infection prevention. Here again, we're starting to see a 100% level of adherence. This was not possible before we were able to present this in a very public way like this in a quality improvement format. Well, let's move on back to infection control. So this slide here is what I believe is the most important slide of this whole presentation. Gelling. Gelling saves lives, and we know that. And by our efforts, and everyone in this room, all of our care environments are using more and more gelling and hand washing techniques. So in summary, what I've tried to present is what I believe the successes we've seen have come through leadership, leadership alignment, and true clinical partnerships with physician and nursing leaders, creating goals in a visible format, getting that information forward in a timely fashion, and then in transparent, of course, but it's really this encouraging healthy competition. And I know that we are all very competitive. I know when I see my own data that I instantly respond and want to have my data the best it can be. So why not use that energy around that competitive spirit to further add value to creating the safest possible environment for our patients? So thank you.
Next speaker will be Mike. He will give us a systemic review in terms of the spine infection.
Thanks, Fungi. So in this presentation, I'm going to focus on risk factors for surgical site infections. It's a picture of a patient of mine. You can see this patient had previous radiation. There's radiation burns, but he developed an infected spine wound with hardware. And you can see we're trying to treat it with antibiotic beads and repeated operative debridements. So from a patient perspective and from a provider perspective, there's surgical site infection is obviously an important issue. It can often result in prolonged hospital stay, readmission, prolonged antibiotic treatment, PICC lines, and operative debridement and irrigation, and other modalities such as a wound vac, as you see here. So from a patient and provider standpoint, clearly this issue is of paramount importance. Conversely, from a medical center standpoint or from a bureaucratic standpoint, this is also getting a lot of discussion. This is off the CMS website. The Centers for Medicare and Medicaid Services have declared certain conditions to be hospital-acquired conditions. You can see here that they're listed right here. And one of the things they include are surgical site infection following orthopedic procedures in the spine or the neck. And in the event of such a hospital-acquired condition, the result would be a quality-adjusted payment. I'm not sure exactly what that means, but I know generally what that means. It basically means medical centers aren't going to get paid to take care of these kind of complications. But if we look, so that's fine. That's from the bureaucratic standpoint. If you think about Medicare and Medicaid, fine. They certainly have their budget issues, and they certainly have a push to increase quality, and they can't be criticized for that. But from a patient and provider standpoint, there has to be risk modification. You look at a patient like this, a 65-year-old diabetic, status post-organ transplant, who's about to undergo an L3 to L5 laminectomy infusion. And you compare it to a 35-year-old healthy patient who's undergoing L4-5 microdiscectomy. I think all of us in the room would easily agree that this patient on the left is more likely to get a surgical site infection, all things being equal. But that being said, such metrics as we see here, these quality adjustment metrics, don't necessarily take into account this risk modification. So what does that mean for patients, and what's going to be the end result? Is there going to be a patient access issue, and are patients going to be selected based on the risks? So we need to identify risk factors. We need to look at risk factors, and we need to identify risk factors, and we need to really adjust risk when looking at these quality metrics. Now, I'd be remiss if I didn't mention some of our work here at the University of Washington, using the Spine Surgical Invasiveness Index to identify risk for surgical site infection and multivariate analysis. Dr. Chapman had referred to our spine end results registry. There's 1,700 or 1,500 plus patients of all surgical spine patients from 2003 to 2004. Literally hundreds of data fields were collected prospectively per patient. So this is a prospective data registry. And in that, we also record the occurrence of a surgical site infection, and we define surgical site infection as those patients who return to the operating room. So this is kind of a busy slide, but the point of this is to show you the extent of the data that we record prospectively, not only the run-of-the-mill things that we usually record, but also did they have a history of congestive heart failure, myocardial infection. You can see the list goes on, rheumatoid arthritis, cancer, liver disease, GI disease, syncope, dementia. What's their diagnosis? Degenerative trauma or neoplasm, where's the diagnosis level, area of surgery, what's the surgical approach, and of course the aforementioned surgical invasiveness index. The invasiveness index was devised by Sohail Merzer and basically assigns a point value for every level decompressed, every level fused, and every level instrumented from either an anterior or a posterior approach. So by giving us a number, we can look at a number and quantify surgical invasiveness, which kind of gets around a little bit about some of the disparities between how extensive a surgery is in some of these other studies. So this is really the money slide from that study. This is our multivariate analysis, or the results from multivariate analysis. Here we found these are our significant risk factors after multivariate analysis. And the way I would read this is those obese patients are 2.24 times more likely to have a surgical site infection than those patients without obesity. And you can see that hypertension played a role, renal disease played a role, diagnosis played a role. Thoracolumbar surgical patients are more likely to have a surgical site infection than cervical spine patients. And of course, the invasiveness index also played a role with all the associated confidence intervals and p-values. And so what we found here is that the bigger the surgery you do, the higher the likelihood for surgical site infection. Now you might look at that and say, well, duh, I mean, that's kind of obvious. And it is kind of obvious, but it's not in the literature. And it actually has been disputed in the literature, and we need to put that in the literature so we can adjust such risks for the future. Now this study does have weaknesses. These data are categorical, not continuous. And what that means is that when we looked at diabetes, we didn't say, oh, this patient has a long-standing history of type 1 diabetes with an average hemoglobin A1C of this. We looked at, did they have diabetes or did they not? Yes or no. And we didn't differentiate between diet-controlled diabetics versus raging diabetics. Same thing with smoking, yes or no. So if someone who smokes 2 cigarettes a day would be in the same category as someone who smokes 2 cartons a day. And this is where we can actually start to decipher or dissect our data even further. So there are some weaknesses to this data registry, but nonetheless, it is an impressive registry. So, we hear about evidence-based medicine all the time. You've heard me mention it a couple of times. You've heard me mentioned by other speakers. And at some point, you kind of get nauseated by the evidence-based medicine and just in terms of what producing level 1 studies, randomized controlled studies. But we have to rely on evidence-based medicine to define our policies and our practices. What's out there? So again, here's another systematic review by Jim Schuster in UPenn, an alumnus of our program. The influence of perioperative risk factors and therapeutic interventions on infection rates after spine surgery. So he looked at 127 studies, again, evaluated them using the grade criteria, and they came up, and it's essentially the study of studies, and they looked at a whole slew of risk factors to see the effect of these risk factors on the occurrence of surgical site infection. And this is basically the money slide for this manuscript. Here in the left-hand column, you can see there's risk factors listed. Here in the middle column, you can see if they felt that these were significant risk factors or not. And here in the right-hand column, we can see the level of evidence. Now, when you look at this, or when I look at this, my eye immediately goes to that middle column. Okay, what are the significant risk factors? Okay, age, makes sense, diabetes, perioperative glucose levels, BMI, ASA, transfusion, surgical approach. But when we look at this slide a little bit more carefully, this is the column which I find is actually more interesting. Look at the level of evidence to support these conclusions. these are largely case control studies. Now, a case control study is not level 1 evidence. It's not level 2 evidence. It's level 3 evidence. So what is the quality of our evidence supporting our information for risk factors for surgical site infection? And this is not even mentioning these other variables. What about the use of laminar flow or betadine irrigation, suction drainage versus no suction drainage, silver impregnated dressing, shaving versus clippers, or antibiotic duration? These are all things that have been looked at in the literature, but there's just not enough information or quality information to make a meaningful statement on. So what they concluded, or the bottom line, is that the evidence is moderate. Now, what does moderate mean? Moderate is defined as further research is likely to have an important impact in our confidence in the estimate of effect and may change the effect. And what they also concluded in the study is that meta-analysis is not possible due to the heterogeneity of these data. The question is this okay? We live in this world of evidence-based medicine, and we're looking at level 3 evidence. Is this okay? Well, there are challenges in doing a level 1 randomized controlled trial looking at infection, particularly surgical site infection. Let's just go through a little quick exercise. Let's say we want to do a level 1 prospective controlled randomized blinded study looking at surgical site infection for one intervention over another intervention or a risk factor. If you look at their infection rates across the board, they range from about 0 to 4%. So it's reasonable to say that we're looking for a twofold difference in effect. If we did a power analysis using their 0.8 and 0.05, we would need about 1,100 patients in each group, so a total of 2,200 patients in this prospective level 1 randomized controlled trial. 2,200 patients is a lot. It's hard for one surgeon to do that. So now we're looking at multiple surgeon. We're looking at multiple center. And we have to bring up the issue of control. What about the heterogeneity of the population, variations in surgery? One surgeon uses Dermabond, another surgeon uses nylon. How do those things come into play? And how can we really control for all other possible variables? I didn't do an estimate of cost, but I would just right now, I'd probably estimate the cost to be in the millions of dollars to perform this study. So it's incredibly challenging to get level 1, level 2 evidence in surgical site infection. So the question of, is it okay that we have these case control studies supporting our practices? In my opinion, the answer is yes. It's not always feasible or ideal to obtain level 1 evidence, and it does take a tremendous amount of resources. I want to end with this study here, which has nothing to do with surgical site infection, but talks about level 1 evidence. Parachute use to prevent death and major trauma related to gravitational challenge. A systematic review of randomized controlled trials. And if you read this caption here, it states that parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved with randomized controlled trials. So what they found in their results, of course, their search strategy randomized controlled trials of the parachute. I think that's kind of where we're at with surgical site infections. So just because we all want and love level 1 evidence, we can't always get it, and we have to be reasonable and logical in how we proceed. So in summary, we do need to, that's not to say that we should stop all research. We do need to continue research. We need to improve our understanding of risk factors and better understand who is at higher risk. And in the future, there really ought to be some sort of risk adjustment. Just because someone's 65 years old and has diabetes, they shouldn't be selected against because they're at higher risk for surgical site infection than a healthy 25-year-old undergoing a microdisc. Thank you.
All right, our next speaker will be Carlo. He's going to focus on the BMP and the infection.
This is an example of a patient, as you can see, who has ankylosing spondylitis. Comes in with a 2-level injury, as you can see on these CT scans, typical 3-column extension injury, neurological deficits, etc., and undergoes decompression in this multi-level fusion, and ultimately ends up with an infected pseudoarthrosis. And so the question that I'll sort of approach in a way is, what's the role of BMP in addressing this issue now with broken rods, increased pain, and draining wound, infected pseudoarthrosis. As well, just garden variety, if you want to call it that, osteomyelitis. What's the role of BMP, which has been used, I don't know if I'd say it's used increasingly, but has been described as a means for effectively eradicating osteomyelitis and enhancing fusion in treating situations that are treating conditions that require operative intervention. And is there a difference between, for instance, this type of situation just described, maybe especially the one on the right where there isn't really a structural deformity, but more of an osteomyelitis with epidural abscess versus this extreme destructive case, which Dr. Howe is very familiar with from his time here as a fellow. And obviously there's no objective evidence for really any of this, or very little objective evidence in the literature, so I'm just going to go over a little bit of what we have. So just stepping back a little, as you're all aware, most of BMP use is off-label. I mean, essentially, if you're not using BMP with specifically an LT cage as a single level anterior fusion in the lower lumbar lumbosacral spine, is basically off-label use. I don't know what the percentages are, but I would estimate that upwards of 70, 80% or more of BMP use is off-label. And we do that obviously because we believe it works, even though the evidence probably isn't as good as our own anecdotal evidence is, let's put it that way. And it has a pretty significant complication profile, as you see from the list that I've given here. And there are also contraindications listed. Some are relative and some are absolute, and many of them are ignored, infection being one of them. Infection is presumably a contraindication to the use of BMP2, and on the other hand, it's used in those circumstances all the time. So is there really any evidence to support its use in that circumstance? The effectiveness, as I said, this isn't a spine study, and there's plenty of literature in the orthopedic and the long bone realm regarding the use of BMP. But this is a Cochrane database analysis, which was just came out recently, which demonstrates that actually the effect on treating acute fracture healing is actually quite modest, and the effect on actual healing of non-unions is pretty much nil, according to this analysis as well. And they actually list one of the adverse events they've noted as infection. So the two issues I'm going to address more or less indirectly, I guess, is does BMP-2 increase risk of infection, and is it a good way of actually therapeutically treating osteomyelitis? So with regards to the first issue, there's plenty of papers that have been published. I'll show some of them that aren't really particularly well controlled. They're class 3 data at best, just like Mike was describing, that look at complication rates with use of BMP2. This is a particularly, I selected this one just because of the number of patients. This is an uncontrolled study. It's a retrospective review. It certainly has significant limitations. A posterior lateral spine fusion, 1,037 patients. And as you see, the deep wound infection, again, uncontrolled, but 2.1% and 1.7% superficial wound infection, pretty reasonable for your standard posterior lumbar arthrodesis. So it doesn't seem that it results in elevated infection rate in this circumstance. Similarly, with a TLIF, consecutive series of TLIF patients, 204 patients, again, uncontrolled study, and a demonstration of essentially equivalent infection rates with treatment of this condition. Now, a controlled study, extension of idiopathic scoliosis down to the sacrum or the pelvis in patients who in one group were treated with autogenous bone graft and the other group with BMP2, demonstrates that there were similar, essentially identical, 4% infection rates in both groups. You can see the rest of the complication profile, and they noted also no increase in adverse events with the use of BMP, which suggests that BMP really doesn't raise infection rates, and that it's a reasonably safe product to use. The most recent one that I've seen come out is this study on posterior cervical fusions. Again, BMP versus no BMP, they saw no significant difference in infection rates. And actually, this study demonstrated a decreased non-union rate with the use of BMP, but also an increase in persistent neck pain with the use of BMP. So a paradoxical result, as you can see from the graphs below. So what about the treatment? So it looks like, at least, with the evidence that we have, and obviously you can find an article to support anything, but in general it seems to be that the infection rates with and without the use of BMP2 are basically equivalent. So the next question is, can it actually be used as a treatment for osteomyelitis? The theory being that it recruits inflammatory cells. The migration of inflammatory cells actually enhances, first of all, the ability of the body to actually fight off the infection, and secondly, the ability to promote fusion across what is often an extensive interbody defect. So there are a few animal models that actually supported this. This is a long bone model, as you can see, a long bone rabbit model, actually an infected long bone rabbit model that demonstrated that with the use of BMP there was substantially greater volume of bone noted radiographically with BMP2 versus no BMP. This is at various time points. And also histologically, where you can see the enchondral bone. For those who still remember the histology, you can see the enchondral bone formation here versus simply fibrous tissue formation. Another segmental rabbit femur model, as you can see, actually shows that the combination, interestingly, in this particular case, the combination of BMP2 and infection actually increased expression of certain genes that were actually, that encouraged bone growth, which was also an interesting finding. Going to a spine model, still an animal model, but a spine model, similar findings, no increased morbidity or mortality with the use of BMP2 with what appears to be an increase in bone formation relative to autograft. So what about clinical studies? There are only a handful of clinical studies that actually looked at this situation, and they're all quite similar. They all, unfortunately, fraught with being uncontrolled, retrospective reviews with very few patients, and that's kind of the nature of this condition. We don't see, and I mean, we see the bulk of osteomyelitis, I think, in the Pacific Northwest, or certainly in the state in this institution, and the numbers still aren't huge. And so this is an example of a series that was treated with corpectomy, anterior reconstruction alone with the use of BMP, and you can see that they had no recurrent infections and no non-unions in this relatively small series of patients. Similarly, one from the same year here, another retrospective case series. This is from San Diego, where they did staged procedure, corpectomy and anterior reconstruction first, either with allograft or cage with BMP in it throughout the spine, whether it be cervical, thoracic, or lumbar spine, and then a secondary posterior instrumented arthrodesis and similar findings. All patients had fusion and resolution of the infection, and their determination or their conclusion was that BMP is effective and safe in this setting. And just to give you an idea, they used it for various indications. It wasn't simply de novo osteomyelitis. These are slides directly from their article. This is, as you can see, a fairly destructive osteomyelitis, and was treated with an anterior posterior fixation, whereas this is a postoperative osteomyelitis, which was also treated effectively with, again, aggressive debridement, anterior reconstruction, and then posterior instrumented arthrodesis. And the third one, similar findings. 20% of these patients were treated only with an anterior approach, and 80% were staged anterior-posterior, and again, no recurrent infections and no non-unions. They all conclude that BMP is an effective means for treating osteomyelitis. But again, no control group. And so the question becomes, what happens if we don't use BMP? And there are obviously studies that have demonstrated the effectiveness or lack thereof of same techniques minus the BMP in the past, one of them being from this institution from approximately 10 years ago, where Jim Schuster, who's now at University of Pennsylvania, former neurosurgery resident here, spearheaded this study. He located many of our osteomyelitis patients and got reasonable follow-up on them, and found that actually a very small percentage of these patients, in fact only 2 out of 47, had recurrent infections, both of which were continuing IV drug users, so obviously had additional sources for the potential recurrence, one of which also had a chronic excoriating skin condition. And so also seems that without the use of BMP, fairly effective treatment with anterior debridement, reconstruction, and then posterior instrumented arthrodesis. Similar study, but done with titanium mesh cages instead of allograft struts from Penn State University, and similar findings as well. They did keep, as did some of the BMP studies, they did keep some patients on chronic suppressive antibiotics as precaution based on the virulence of the pathogen or perhaps of the susceptibility of the host. But in the end, their results were also quite encouraging without the use of BMP. So I look at these 3 cases that I showed at the beginning. We have a patient here with a fairly destructive cervical osteomyelitis, 3-level condition. She's actually a patient who's not a particularly robust, she's not particularly robust health-wise, but still I really see from either the literature or my own experience very little reason to subject the patient and the institution, for that matter, to the increased costs and subject the patient to the increased potential complications associated with BMP. So this patient was treated with a staged anterior reconstruction and then posterior instrumented arthrodesis, and this went on to heal nicely with no recurrence. Here's another example, patient on whom I have 10-year follow-up, just simply because he had a disc herniation down in the lumbar spine down the road. So he had this radiograph which demonstrates a nice reconstruction of with allograft rather than titanium mesh. Again, no use of BMP. Now this case is, I think, a little bit different. I think this patient's at higher risk. She's already established, has an established non-union, an infected non-union. You can see she has a biomechanically disadvantageous situation with long lever arms on either side. She's not a particularly healthy person either. She's diabetic and obese. And I felt that that combination of factors put her at increased risk for a recurrent non-union, really, or persistent non-union, which was my greater concern. So this is a type of situation where I felt that the use of BMP was warranted and did so. And she went on to heal, and this is 1 year. I guess I'll never know whether she healed because of, in spite of, or somewhere in between with regard to BMP. And that's pretty much what I've got.
Our next speaker will be Paul Pottinger. Dr. Pottinger is the associate professor of our infection disease division here, and also he's the associate director for the training program of the infection disease, which is one of the most prestigious program in the country. Thanks, Paul.
Thank you. My humble objectives for the next few minutes are to talk with you about a germ doctor's perspective on ways in which we can really establish a diagnosis of infection. We've seen a lot of obvious cases. Sometimes it's not so obvious, at least to me. When I'm not in the operating room, it's not clear to me what's going on in there and the magic, what goes on behind the curtain, is that what they say in Wizard of Oz? What's actually happening in there? But when we do have an infection, how do we choose antibiotics? That decision is becoming more and more complex over time. The bugs are not getting any less smart. We seem to be, they don't seem to be. And obviously to talk to you about ways to collaborate across disciplines. We'll talk about also epidemiology, like the biggest, how many infections are we seeing in America? And I may have missed the comments from last night. The best study of which I'm aware was a study looking at about 100,000 cases retrospectively from 2004 to 2007. And the numbers that I've come up with are exactly what we've seen here too. About 2% of surgical cases, whether you're talking about TLIF or microdisc, will end up coming to an infection. So it's a huge problem, and I've summarized that for you in your printed matter as well. Level of evidence, it's exactly what we all know. The level of evidence is rotten, and yet the problem is very real, so we're stuck. You know, when I do a PubMed search, I find 360 hits with that particular combination of words, and I think it's pretty clear that someone, some august group, perhaps some of you are in such a group, need to sit down and synthesize this. We're not going to get that level of evidence that we want. This is what we've got. We'll keep the science moving forward, but how do we integrate what we already have? Unfortunately, Cochrane, to my knowledge, has not stepped up yet. Maybe that's okay. I don't find anything on the AAOS website in particular, and you know, there is, and I'm a big fan of the ID Society of America. I'm a card-carrying member. I should have my card with me today. They're terrific because they reach out to other professional societies, bring them on board to develop these guidelines. Those guidelines are still in process and evidently won't be due until fall of 2012. In absence of those guidelines to walk you through, I'll tell you what we do here at UW. So number one, what's a surgical site infection in the spine? A very nice paper from Dr. Tony Barrett and colleagues at the Bone Infection Unit over at Oxford. They see the toughest cases in all of Great Britain. So they are certainly a high-level referral center. And the presenting signs and symptoms of infection, you know, a lot of these folks had nothing but pain. First of all, number one, in 30 of these cases, there was no evidence from the notes that they looked back in time to see why the patient had an infection. Must have been glaringly obvious, I suppose, but actually it wasn't in the surgeon's note. Number two, most of these folks had either back pain or an open wound or a sinus. In some cases, God forbid, hardware was protruding or was becoming prominent. So it's, in the case of an open wound or a sinus, I think it's relatively straightforward. If it's just back pain, it's that careful history, physical, and potentially imaging that may be super important. It's certainly not your biomarkers. Right? So in this particular series, just doing a good old blood test, what I do, the most invasive procedure I do, I guess, is look at a gram stain or review a CBC. It's just not helpful. Of all the inflammatory markers, CRP seems to have the best negative predictive value, but the white count was distinctly unhelpful. In fact, it almost looks like it's a protective factor. And finally, in terms of the timing, unfortunately, there's really no way to say that the timing of your patient's presentation with respect to the index surgery can help you decide. In this particular series, the tall, dark graphs, both for Staph aureus and for Propionibacterium acnes, the median time of diagnosis was between 1 and 2 years after the time of their surgery. So we focus a lot on surgical site infections presenting acutely within the first few days, God forbid a week after the operation. Often it is much delayed, and that is a huge problem for everyone involved. So it's one of those things. It's hard to define. We sort of know it when we see it. At least often we think we do. And I would suggest that it's unanticipated postoperative surgical site inflammation, which may be superficial or deep. There may or may not be systemic signs and symptoms. And the patient may or may not even have hard concrete changes with respect to their imaging. I'm a germ person, so I love getting deep cultures, and if I see a pathogen come out of somebody's spine, then I feel really strongly that this patient clearly has an infection. So often the question is, should we go in there and even look to see whether this patient has an infection? I would also emphasize that, although we don't like to say it because we don't like doing tests of cure, the truth is if you give this patient antibiotics and they seem to get better, that may have been a surgical site infection. The problem with doing that is we've just potentially dramatically reduced the ability of us to actually cultivate this from the deep surgical site. We don't know our pathogen. And unless there's appropriate surgical co-management, it's unlikely that we can actually achieve a durable cure, at least with respect to deep infections. And you all know this already. Superficial infection is what we see. There's a red wound and there's not much else going on. Your patient is not likely to be febrile. There's probably not a significant amount of fluctuance or tenderness far away from the actual surgical site. That's easier. The question with respect to deep infection is a little bit more complex. There's all sorts of gradations and subclassifications, I think, for deep surgical site infection. Subtissue infection only, is there an abscess? Is there actually intact fascia? If that fascia is intact and it's just down to the fascia, but the fascia doesn't seem to be involved, then I'd call that a soft tissue infection there. If the bone is involved, if the disc is involved, that's obviously something different, and in either case, there may or may not be indwelling hardware, which makes our lives more complex too. I think that when it comes to making a diagnosis of infection, it's your clinical impression overall, but I want to talk briefly about diagnostic imaging. Boy, it's a problem. If you're trying to rule out the presence of a deep infection, we all want to take a picture, at least on internal medicine side. We want to get a picture. Show me the imaging. And sometimes that's helpful. If there's loosened pedicle screws, if the rods seem to be migrating, if the hardware isn't where it needs to be, then that patient probably needs a surgery anyway, either to get it out, to reposition, and certainly to debride at that time. But that's not often the case. So frequently, when we do push to have our patients sent for imaging, there's a subcutaneous fluid collection. That may be a seroma. That may be something that's actually not entirely unexpected. And the question for us is, has that happy, healthy, aqueous home become culture medium for germs, whether they're there? Imaging alone may not give you that answer unless there's a significant amount of surrounding stranding, erythema, and obvious enhancement with respect to giving contrast studies. When it does come to going to the operating room, just a couple of words of wisdom from someone who's been working in the lab for quite some time. Not all specimens are alike. This is what we use at UW Medicine. It's called an alginate swab. It's basically a Q-tip, and it's got this gooey piece of slime that comes from seaweed, actually. It's where the alginate comes from. They're ubiquitous. Every exam room in both of our hospitals has this. Every operating room has a whole gross of them sitting there, and in very few occasions should you as surgeons even consider using these things. They're just the bane of our existence in the lab. They really are problematic because we can't tell exactly how many organisms are present. With a piece of tissue, we can say, is there something superficial? Is it deep? Is it invading? It's impossible to test by PCR because what you'll amplify is seaweed DNA that comes from the alginate, or you won't be able to get a signal at all. And the culture yield, the absolute sheer tonnage of germs, is clearly going to be less. They are convenient, and they're not necessarily against the rules. This is a patient who we admitted to our hospital just recently, 3 weeks after a microdiscectomy and surgical repair for his spinal stenosis, and he came in with fever and pain, and the wound at 3 weeks, I'll see if I can zoom in here, make it bigger for you. So 3 weeks out, the wound looks like this, and at the inferior margin, in fact, there's some purulent exudate here. It doesn't look the way it ought to at 3 weeks, but it's not overwhelming. Now, at UW, we have an absolutely outstanding surgical training setup, and the residents are great. They looked at this patient, they said, it looks like you've got a superficial wound infection. Take this oral antibiotic. He's allergic to virtually every antibiotic that's out there. The patient actually ended up on doxycycline, and the thought was that this was going to be okay. I suggested, when I heard of the case, that they take a swab and see how far, well, it's like Alice looking down the rabbit hole. How deep's a rabbit hole go? How far can you probe? They probed to 4 centimeters, and they came out with purulent, creamy exudate. The gram stain that was obtained showed this, which is gram-positive cocci in clusters. And again, the feeling was, well, maybe it's coag-negative staph, maybe it's Staph aureus, doxycycline should be okay. Now, the surgical faculty member who knows this case, was a very respectable and lovely quotient of gray hair, said, no, we're going to the operating room. And the patient went immediately to the OR. He said, I don't care how deep you think it is, that's Staph aureus. And it's that experience that you have as faculty to say that you've seen this carnivorous, rapacious germ, probably no matter how deep it is, you're worried that it may actually intrude the fascia and become a true pyomyositis. This patient had, in the operating room, a classical, obvious case of deep surgical site infection that clearly needed a washout. And it was that experience of the surgeon that really made a huge difference. And we also got the answer. Methicillin-sensitive Staph aureus, we can switch him over to antibiotics, mop him up. At the time he came out of the operating room, his blood cultures turned positive. He's actually septic with staphylococcal sepsis that had not initially been appreciated. So, Once in a while, you can use a swab. In this case, it was important. Otherwise, please, if at all possible, get us tissue down to the laboratory. We can actually send a stat gram stain from the operating room. I think that really helps if you see nothing but gram-positive microorganisms. Getting your patient empirically onto vancomycin is the right thing to do. If there's gram-negatives, vanco simply won't cut it. And thus, it can be helpful actually to get that stat gram stain. You're certainly going to send both aerobic and, please, anaerobic cultures. A leading, I think, greatly underappreciated pathogen in these infections can be Propionibacterium. P. acnes does not grow under standard aerobic conditions. Please work with your laboratories to make sure they know when you send a specimen from your operating room, they need to look for P. acnes. Because if they don't, they'll cut off those cultures at 5 days and you'll end up with a sterile culture and not know what they've got. They may get better with vanco, they may not, but knowing that it's P. acnes really allows us to tailor our therapy and get them onto beta-lactams if at all possible. And finally, if you're thinking about molecular, if you're thinking about looking for coccidioides or some other funky fungus, please call for ID. ID is actually very helpful and should be instrumental in getting specialized handling in the laboratory done for you. The magical number that we dream about is between 3, I guess 4 is between 3 and 5, so 3, 4, or 5 specimens, and is what we think about at night when we go to sleep. So fluid, soft tissue, bone, and if you actually explant the hardware, send the whole thing down to the lab. I'm famous for bringing feet and arms and other amputated limbs down there. The lab can work on this to try to figure out exactly what the infection may be, and hardware explants should be no exception. Deep specimens, always preferable, please, to superficial. So, in terms of antibiotics, number 1, if it's superficial, by definition, I think I would call it superficial if you don't need a washout. If you're going to use antibiotics alone, that's how we would define it, as a superficial infection. I would choose that antibiotic based on all the usual stuff that you do with any patient. What are they allergic to? What can they afford to take? What does it involve in terms of antibiotic interactions with their other medicines? And for goodness sakes, what have they been colonized with previously? In general, if you're trying to cover gram-positive cocci in 2011, at least here in the Seattle area, trimethoprim sulfa, either 1 or 2 double-strength tablets, 2 if they're big, 1 if they're a normal-sized human, twice a day for 14 days, or if they can't take that, doxycycline is a reasonable choice as well. They're not perfect. These don't get your total abundance of gram-negatives, and they're not the ideal streptococcal coverage drugs either. But it's a reasonable way to start and then follow those patients up and extend the therapy or change with ID if they don't get better. In deep surgical site infection, of course, this is a surgical condition. They need to be washed out. Antibiotics alone, very unlikely to work. There is this controversy that I hear sometimes, what should we use in the operating room to wash these patients out? The simple answer, and savings of time, is I don't so much care what you use as long as you use a lot of it and you use it early and often. So we know that non-sterile solutions, especially povidone iodine, those can actually introduce new pathogens into the field. As long as it's sterile, I'm relatively happy. In primary prevention, there is this intriguing, although still yet, I think, to be fully substantiated experience with using vancomycin powder. Can we actually just put powder right into the wound and expect those infections to go down? In the papers that are published in this non-randomized prospective experience, they do seem to have a reduction in their rates if you have one surgeon who uses antibiotic powder and one who doesn't. But the reality is that those are not truly randomized controlled trials, and I think that remains entirely unsubstantiated. If that is your practice and you're finding that you don't have a significantly high infection rate and you want to continue it, then I think it's reasonable to do so. Talk to your partners, see what they're doing, see if you can do your own case control study. That's how the literature, I think, has to grow. So for washout and debridement, I think you can use anything that's sterile with confidence. In general surgery, they use bacitracin. Most often, I think in orthopedic surgery and spinal surgery, it's usually sterile water or saline mixed with vancomycin. That's totally fine. You're not going to hurt your patient with vanco. And although I'm a steward of antibiotics and I'm supposed to be thoughtful about the use of antimicrobials, I actually don't care what you use so long as it's sterile and so long as it's probably not an aminoglycoside. Gentamicin, tobramycin, these are potentially nephrotoxic drugs, which can indeed be absorbed right through the wound bed and thus lead to delayed onset of renal or CNS toxicity. It's also an interesting idea about wound vacs. I think there may indeed be a nice role for wound vac in those patients who you don't feel you can get a good approximation early on. This particular paper is starting to show its age, but it remains intriguing. 20 patients who had a deep surgical site infection, they all got a good washout. They all had a vac placed, and they were able to get closure, delayed primary closure, at 7 days of treatment. They also got a lot of antibiotics. The good news for me was that they all had kept their hardware, thank goodness, at least 10 months of follow-up thereafter. So this is what these patients looked like. It's black and white. That's from their paper. 4 weeks into their case, they had done the washout, they placed the vac, and the pictures look really nice with respect to those particular papers. So the question for me is really about hardware. When does it need to go? When can we consider keeping that hardware in place? If the hardware is not where it needs to be, then it probably needs to go anyway. It's possible for us to treat those patients with antibiotics, but I would say that the antibiotics are relatively unlikely to work if we have loosened hardware, of course. However, if the hardware is well fixed on imaging, you can consider doing a washout and trying to keep that hardware in place. That's what we're here to do. And if you have experience with your local friendly ID doc who always says take out the hardware and doesn't want to hear from you, how did it feel, how does it appear, what's the patient's clinical goals, then you have a problem in communication with your ID team and they need to get their story straight. So again, with respect to the bugs that are involved, this particular series with more than 100,000 cases, they didn't describe the microbiology. We have smaller numbers in terms of microbiology to describe. In the United Kingdom, it's often propionibacteria or coag-negative staph, and Staph aureus less so. Look at your own, please, your own personal experience with your patients and see what the bugs are that the lab's able to cultivate. If you're seeing a spike in one particular germ, it might even be necessary to make a modification with respect to the prophylactic antibiotics that could be necessary. If you have a problem with MRSA, then you can talk about screening preoperatively and potentially adding vancomycin for your routine prophylaxis. But unless you have a problem with MRSA, you should stick, for example, with cefazolin. I would say that what we try to do in choosing antibiotics is we target the bug. We want to try to kill the bugs and make it as pathogenic as we possibly can for those bacteria to grow. But it has to be tolerable, and is your patient pregnant? What can they afford? It turns out that we have a health insurance issue in this country. Some people just cannot get drug X, even though I know that it's the best thing for them in terms of getting them better, and we have to negotiate with them around that. It's a huge problem for us. Often we'll start IV up front and then transition to PO, and of course the question is when to stop. In the interest of time, what I'll say is that I think my practical advice would be that if you have a patient who has either a gram-positive stain in the operating room or who has nothing showing, it's likely to be a gram-positive. That's based on the statistics we just looked at. Vancomycin, your friend for empiric coverage of deep infections in the spine. And I think the point is that we really want to know what that germ turns out to be so we can step them down to a beta-lactam if at all possible. If you ever have a choice between vancomycin and cefazolin, for example, go with the cefazolin. That's always going to be a more cidal, active, bacterial killing type of drug. And we always reach for that if at all possible. Combination, if there's hardware in place, of course, I'll reach for rifampin. I would say that when you try to dose vancomycin, one size does not fit all. This is a funny country. We have a shrinking economy. We have a growing body mass. I don't understand that paradox. But with the embiggening of the American population, it turns out that a gram Q12 of vanco is simply not enough. It should be based on body weight. I like to load these patients, 30 mg per kg IV, and then step them down to 15 mg per kg IV. You're shooting for this proverbial target of 15 to 20 because over time we see an increase in the MICs in Staph aureus to that particular drug. ID can help you do this. If it's a gram-negative or a yeast, the bottom line is there's such an incredibly varied group of microorganisms which have such a broad spectrum of resistance patterns that I think it's time for an immediate ID consult in those particular cases. In fact, I think you ought to call ID, in my opinion, if you have any deep spine infection. We're always happy to be involved, and hopefully we can bring value to that patient interaction. If it's not clear what the diagnosis is, if the patient's allergic to more than one antibiotic, if the patient's had other infections previously, we want to hear about these folks. Certainly the bacteremic patient, if you look at the lab report and it's a Latin name, you can't pronounce that bug, call us, we'll help you with that too. And if you anticipate IV therapy, we're happy to take that burden from you and share the hard work of outpatient antibiotics. So when I talk with our ID doctors, the bottom line I think for this is to say that it's just super duper important for us as the internists to talk with the surgeons before we put anything in the chart and before we go to see those patients at the bedside. I want to know what you saw, what it smelled like, what it felt like, and more importantly, what happened prior to the case. What's that patient's expectation? Does she want to go back to the operating room, or did she say, I'm never going back? Some patients are never going back. And if she's never going back, that's fine. We'll craft a customized long-term suppressive course of antibiotics which will allow her to go to her granddaughter's wedding or whatever the case may be. Or is this a young athlete who says, I'm going to stand on top of Mount Rainier, and if it kills me to get there, I'm going to do that? Okay, we're going to work with that person too. But that individualization of antibiotics and treatment is just so crucially important for us. The major unresolved questions are the ones that you all have for me, I'm sure. Is it IV, is it PO, or is it both? We usually start with intravenous antibiotics for deep infections. I'll often then transition them to oral if there's retained hardware. However, if it's a case of someone who just can't get an IV in place, we can indeed start with oral antibiotics alone. There is a randomized trial called OVIVA, oral versus IV antibiotics. It's now enrolling. Within the next 2 years, I hope to be able to give you some primary data. Should we give one drug or more? Almost always one drug. The only time I add a second drug is if I can't get coverage of a polymicrobial infection, or again, if I think there's retained hardware and I need to cover that patient with rifampin to get better penetration into that hardware-affected area. And finally, when to stop. Medical school, what's an infection? Residency, how to start antibiotics. Fellowship, how to refine that regimen. Then there's faculty life. Like, how do you stop? This is the question. I'm still struggling with it all these years later. I got to tell you, in general, what we do is 10 to 14 days if it's superficial. If it's deep, soft tissue, we'll start with 14 days and consider extending if the inflammatory markers haven't come down. If it's osteomyelitis, cat's out of the bag. We're going to do, number one, surgery, which is your job. And then my job is to mop up that last 5% that may have hidden your very good garden hose in the operating room. So I may treat these patients for 6 weeks or longer with an oral mop-up regimen, depending on how much hardware is left behind and what their inflammatory markers look like, too. So in summary, I would say everything I've just talked about, it's all secondary to prevention. Prevention is always job one. When patients do get into trouble, please work with us to help get a firm microbiologic diagnosis and to let us help take some of the burden off of you when it comes to outpatient intravenous antibiotics, because it is quite a job. I thank you for your attention.